Hepatitis C infection is one buzzword which you need to remember. One of the forms of vasculitis, cryoglobulinemia, and the MPGN are closely related with each other. That's the reason you need to remember. Generally prognosis is poor and 50% will go into chronic kidney disease and treatment is not that effective. Now what is very characteristic of MPGN? If you look at the lobar pattern of the nephron, there is an accentuation as such, it is being broken down into multiple lobes with an increased mesangial cellularity is very, very characteristic feature. Of course, in addition to that, capillary walls are thickened, etc., etc. If you take the electron microscopy, where do you find deposits? Subendothelial deposits are the characteristic feature in case of MPGN is what you need to remember. Then in the MPGN type 2, if you look at it, you have got multiple deposits which are basically what you call very dense. Hence MPGN type 2 is also called dense deposit disease is the name which is being given, that's all. Then the next important entity is post-streptococcal glomerulonephritis. If I ask you a question, what is the most common cause of the nephritic kind of a syndromic presentation? It is PSGN which is responsible. It is group A beta hemolytic streptococci infecting the upper respiratory tract, pharyngitis. Similarly, the group A beta hemolytic streptococci can also cause impetigo of the skin. Even that can lead to glomerulonephritis. What is the difference between rheumatic fever and glomerulonephritis? Rheumatic fever is only caused by pharyngitic strains, not by skin. Glomerulonephritis can be caused by both pharyngitic and also skin strains, and it takes 10 to 14 days post infection for the glomerulonephritis to develop. Hematuria, edema, hypertension, proteinuria, and a low complement levels is what you come across. Here we need to have a small caveat about the complement levels in PSGN. If you take lupus nephritis, doctor, what is it because of? Immune complexes go and deposit in the kidney and destroy the kidney. Every time immune complexes are forming, they will consume the complement and complement levels will be low. Even PSGN also is an immune complex attack on the glomerulus only. Hence there will be low complement. But there is a speciality in this. In PSGN, the low complementemia become normal complement within 6 weeks. In spite of 6 weeks is over. Still if the complement level is low, it is not PSGN. You are hanging something else and thinking that this is the elephant, which is actually a serpent. So you must be sure when to recognize it. So what is the important clue? 6 weeks ke baad complement which is low is expected to normalize in PSGN. If it doesn't, it is against the diagnosis of the PSGN is what you are going to ultimately remember, doctor. Now, AS4 titer is elevated. Usually it is self-limited, good prognosis is there. Mainly supportive therapy in a PSGN patient. BP tablets, loop diuretics for edema, antibiotics, really needed or not is a big controversy, because if you take care of anti-fire measures after the hut is burnt, what is the use? When person had sore throat, that time if you use it, maybe it is helpful. It is a consequence of the streptococcal infection already which is established. Now we go to the next important entity which is called as good Pastures syndrome. How do you describe this? There is a proliferative, rapidly proliferative crescentic glomerulonephritis is the common presenting feature of good pasture. Additionally, they have hemorrhages into the lung, and the immunoglobulin G anti-glomerular basement membrane antibody is typically positive. They will have fever, myalgia, rapidly progressive renal failure, hemoptysis, cough and dyspnea. Why there is a cough, dyspnea, hemoptysis in these people? Because you know that alveolar capillary membrane has got a basement membrane. So these anti-GBM antibodies will attack even there, and that lead to alveolar hemorrhages, which lead to development of hemoptysis, dyspnea, etc., etc. Generally, the dyspnea, cough and lung manifestations, hemoptysis, they precede the renal manifestations of hematuria and renal failure in the case of the good pasture. There is a 45-year-old man who was admitted because of the respiratory failure due to the massive hemoptysis along with acute renal failure, and later on post-mortem when autopsy was conducted, there are multiple foci of bleeding into the lungs, which is being demonstrated in case of good pasture. Now, you have taken a renal biopsy. What do you expect to find in good pasture? As we said, good pasture's glomerulonephritis is a crescentic glomerulonephritis. So, if you look at the glomerulus, all the parietal epithelial cells of the Bowman's capsule are hyperproliferative and led to the development of crescentic glomerulonephritis. What are the other entities where crescentic glomerulonephritis can be found? Other than anti-GBM antibody disease, SLE, any vasculitis or good pasture. These are the three common reasons for the development of crescentic glomerulonephritis with the RPGN is what need to be remembered. There is IgG deposition just like a ribbon. There is a deposition along the glomerular basement membrane, and this is the 35-year-old man who had alveolar hemorrhage because of the good pasture syndrome is what you need to remember. Then if you look at the other causes of secondary glomerulopathies, what are the causes? Dysproteinemia, sickle cell nephropathy, HIV nephropathy, they are the other causes. Now let us take up few comments on HIV nephropathy, which can become rarely a short answer question in the exam. We are all loving and living in the era of HIV. So, a HIV patient can end up with a cardiologist. Why? Pericardial effusions, then lymphoma metastasizing to pericardium leading to malignant pericardial effusion leading to cardiac tamponade and death. HIV by itself can lead to cardiomyopathy. HIV can come to the kidney and it can destroy the food processes, podocytes, and can lead to development of nephropathy in the kidney. So, if we get HIV, there are hundreds of reasons to die. Lucky we will be if it is an easy way of dying. So, doctor, what is HIV nephropathy? Proteinuria, edema, hematuria is the presentation. It often resembles focal segmental glomulosclerosis in its appearance. You can treat it with prednisolone, ACE inhibitors, antiretroviral therapy. Just I will give you one FSGS and HIV nephropathy. That's all you need to remember as undergraduates. This is the renal ultrasound in a patient of HIV presenting with proteinuria. What did you see in this? Normal sized but extremely echogenic kidneys. Extremely echogenic kidneys is a very characteristic feature of HIV nephropathy. Why there will be extremely echogenic is my next question to all of you. If you do the biopsy, a special variety of FSGS will be found in HIV nephropathy. It's called collapsing variant of FSGS. You see, this is the entire glomerulus way, it got pushed to one side and it got collapsed. Collapsing glomerulosclerosis And if you look at the interstitium, it will all be filled with proteinaceous scars which fill the dilated tubules. That describes the renal biopsy of HIV nephropathy. And if you do ultrasound, this colloid filled dilated tubules of a collapsing FSGS of a HIV nephropathy presents like a hyperechogenic kidneys. This much if you know at MBBS level, examiner will get heart attack. At least FSGS, HIV. If you know, oh, I am very happy. Then those who have endocarditis can develop glomerulonephritis because of the immune complex deposition. Vaginals can be one of the causes of secondary glomerulopathy. Polyarteritis nodosa can involve the kidneys and lead to the development of secondary glomerulopathy. So that is all the story of glomerulonephritis. So summarize, doctor, you have primary, secondary. In the primary we discussed minimal change disease, membranous, FSGS, and all the remaining things, diabetic nephropathy, hypertensive nephrosclerosis, HIV induced nephropathy, MPGN type 1, type 2, all these things into the secondary form. So this is the broad division, 2-3 points about each of them. Yes, you can be able to write a essay on glomerulopathies. Now doc, the next entity is tubulo-interstitial diseases. Every day after the class is over, at least we will cover 30 to 40 pages of Davidson. So you need to go back and read that little book post dinner, just like you read Tinkle before going to sleep. Read Davidson and sleep. All dreams you get walking into that nephron world of fairy tale, everything. After waking up, you can just write your dreams in the question paper. You get the distinction. So, but don't forget to not read, don't forget to read Davidson before going to sleep. Okay. What is the other story about Bailey? In our days they used to say, read Bailey daily. Then one of our friends added, this rule applies only for the last 15 days of the final year. So there's an added comment. So that's the reason. Now the exam date has not come. When? Feb 1st. We have got huge, large amount of time. We can bring even few nephrotic syndrome patients, my MS patients, and have a case discussions also, I think. Luxury of time. Feb 1st. Okay, that's good. Then in that case, we are a little more relaxed.